And she's like,
Good morning. I do need somebody online to answer me whether you can hear me or not hear me.
Yes, we can hear you.
Thank you. Thank you very much. Brooke, I'm gonna have you go first.
okay, he bailed on you.
Well, he just said I'm just gonna have to,
This is our old, the old one that he was 110 pounds, so I think that's the one. That's good.
good morning to everybody online. Appreciate you joining us. And for those of you in person, we're gonna get started today. So May 12th audit review. I got a couple things I want to talk about after we're done, but the first one we're gonna do is Brooke's gonna do a STEMI.
Thank you. Good morning. Welcome to May. We made it to the winter. Okay, so the first case we have the Arizona one.
Oh.
Now I really screwed it up there. I can't be trusted. I tried to do it.
Jeez.
It's Jimmy's fault, really.
It is Jimmy's fault right there.
It's really just. No, my error word. There we go. Okay, I don't know what I hit. I'm sorry.
Just those.
Just those, okay. All right, sorry. Moving on. All right, our first case comes from Clark County EMS. 911 was dispatched to the subway, Casey, Illinois. The driver of one of their delivery trucks was experiencing chest pain. EMS arrived to find a 58-year-old, unfortunately non-English speaking, I think he was from Russia, reporting chest pain that radiated to his left shoulder. They did EKG, several of them actually, including a right-sided EKG, which indicated a lateral STEMI. They transmitted those over to Union, and the STEMI alert was called ahead. They gave him a 15-minute ETA. He got to ER. They did another EKG, which confirmed the STEMI. He had a front cath, which revealed 100% thrombotic lesion to the proximal first obtuse marginal branch. This was successfully stented. He was taken to the ICU in stable condition and was discharged the following day. So there are your run times. Everything looks really good. All of our goals were met. Again, we're just looking at getting that cath lab activated once EMS sends in the EKG. So we're working on that, but everything looks great. Everybody's times look really good. So first medical contact to balloon was 84. Union door to balloon was 43. So nice work there. There are your EKGs from EMS. And I can see that. I'm sorry. There's your cath images. Definitely 100% occlusion. Successful stenting with restored blood flow. Despite the language barrier, things were pretty quick on scene. I think they were able to get his wife on the phone, which helped. Rapid assessment, EKG, IHERN called in, EKG sent in. All the goal times were met. Really nice work to everybody there. Next one is a 50-year-old male. He called 911 because he had quote unquote heart problems. EMS found him in his bed with a CPAP on. He was pale and diaphoretic. He stated he just did not feel right. Past medical history is significant for COPD. He's a smoker, obesity, obstructive sleep apnea, diabetes, pulmonary hypertension, and coronary artery disease, which is a lot for a 50-year-old, in my opinion. Initially, he refused transport to the hospital, but EMS encouraged him to go get care because of the critical nature of his situation. They were able to finally get an EKG. It did show elevation in leads 2, 3, and AVF. They transmitted that over here to Union ED, and the STEMI alert was called in. Cath revealed he had a total occlusion of the RCA, which was successfully stented. He was also sent home the next day, and I checked up. He followed up with his cardiologist. He's doing well and participating in cardiac rehab. So nice job. Again, run times, everything looks great. Union door to balloon was 53. First medical contact to balloon 70, well under our goal of 90. So nice work there, everybody. I couldn't find the EKG, so this is Union's EKG. So you can definitely see that there. Yes. Cath images, right coronary artery was successfully stented, blood flow restored. Again, highlights, STEMI was called in, EKG was transmitted, rapid assessment, run times are excellent, all the goals were met. Like I said, we're still working on getting that activation upon EMS. But thank you guys, everyone does a nice job and we appreciate you.
Thank you, Brooke. Appreciate that very much. Good cases there.
Yeah.
Next up is gonna be Beth Harrison. She's gonna do our stroke reports.
I confirm they work now.
Yeah, Brooke got the kinks worked out.
I just screwed up first.
This report is from Clinton.
Other arrow.
They're, well, okay.
There we go.
It's a 59-year-old female. She was independent, lived with family. She did have a history of CAD with angioplasty, hyperlipidemia, hypertension, diabetes, but not currently on blood thinner, which is kind of surprising with her history. EMS was dispatched to her residence. And upon arrival, they found her sitting on the couch being held up by her family members. They stated she was fine, that had the sudden onset of symptoms and fell over onto the couch. She was unable to speak. She was flaccid on the right side and had a right facial droop. Her last known low was established about 5:55. Her finger stick was 120, GCS 11, sinus rhythm, blood pressure was 232 over 132. Pulse was 90, respirators 14. Stats were good on room air. They did start 20 gauge IV. She was able to pivot to the cart. With those symptoms, you're probably not surprised that her Cincinnati scale was positive, and her van was positive for aphasia and neglect. Stroke alert was called to Clinton by IHERN with an ETA of 45 minutes. Our run times, EMS was notified at 6, so the family did call very fast. Dispatch was at 6, en route at 6:02, on scene at 6:07, not patient at 6:08. Depart times were good, 6:19, at the ER at 6:23, and transferred to hospital care at 06:25. They did follow our protocol. They went directly from CT to CT from the EMS cart. Her NIH was 10 when she arrived at the hospital. CT head stroke was at 06:34, and it was negative for a bleed. Teleneuro was consulted. TMK was advised. Blood pressure was 180 over 110 still at the hospital. They did give labetalol at 06:57. Rechecked that blood pressure again, and they were able to administer TMK at 07:03. Little bit, there's a 35-minute door to needle time, which is a little bit past our target of 30 minutes, but it would be excluded from our measures because they had to treat the hypertension. So a really good outcome for having to stop and get the labetalol. CTA was completed at 07:34 and no LVO present, which is kind of surprising with the severity of her symptoms. 70% stenosis of the left ICA, and she did come to the Union ICU by a ground transport. She was moved to ICU, the MRI at 06, up the next day at 04. The next day, the report being 0600 showed multiple scattered acute infarcts of the left cerebral hemisphere. So usually when you have those scattered, it's usually a cardioembolic event, which was probably that carotid throwing clots. Morning after receiving the TNK, she only reported numbness, but was able to ambulate 150 feet. And with assistance, gait was unsteady and her aphasia continued. She was discharged to MRU. Great strengths with this was the Cincinnati scale was completed, the vein was completed, the stroke alert was called, and the EMS had some great documentation. And some very good things that are coming, some exciting growth. I know that you guys got some education on the new EMS protocol recommendation from American Heart for stroke, which is kind of exciting. They don't have as much bearing on us because we don't have multiple levels of stroke centers. Now, if we had a comprehensive or a thrombectomy ready in our area, it could make a big difference for our hospitals, but currently we don't. So you're not going to bypass us and go all the way to Indy. But the TNK, that window has been open from 4.5 hours up to 9 hours.
Huge.
Huge. It's really going to make a huge difference when you see those wake up strokes come in. You know, because we had those people, they were fine when they went to bed, and here we are 6 to 7 hours later, they wake up and they have these symptoms. But now they are actually in the TNK window. It does, and in some cases, I've used even giving it up to 24 hours with good results. So that's kind of exciting. I'm sure we're gonna see a lot of growth with the TK given. But the only thing is, if you are giving it that enhanced window of 4.5 to 9 hours, you have to have advanced imaging. You have to be able to do a CTP or an MRI with the different flares. None of us can do the MRI that fast. It's just we don't have that capabilities because it's so busy. But we do have a CTP here at Regional, I'm not here at Union. And we have offered it now at Clinton. They're installing it now with getting training. So within a month or two, Clinton will have full access to do CT perfusion brain scans, and they'll be ready with our rapid software. So that's a really exciting thing, because if you have someone in the northern part of
Yeah.
yes, you're not gonna go to Hendricks because we're gonna have better capabilities in Clinton. So what the CTP does, it looks like a part. Now, you already had the stroke, this much of your brain's already dead. But we're looking at this part that surrounds it, which we call the penumbra. That's your salvageable brain tissue. And if we do that CTP 9 hours out and we still have brain that is salvageable, we'd go ahead and give that T and K and then transfer them to Indy if appropriate for a thrombectomy. So it's really exciting. Another thing that's really going to happen, it's going to make a big difference for our stroke patients and our neuro patients in general. We are starting inpatient hospital rounding via teleneurology at Clinton and at Regional. That will both start around June 1st. We've got to go through some credentialing here at Union, but I've been working with them. So what we'll do, we're going to have a set time every day at Clinton and at Regional. We're going to make an appointment, so to speak, and then we'll be able to do these tele-roundings between 2 and 5 in the afternoon. So they're going to be able to keep more stroke programs, more stroke patients in those hospitals instead of having to transfer everybody here. And we all know our bed situation. So it's really good that we can keep those patients in those facilities or in their own community at Clinton. So it's going to make a huge difference. We cannot add CTP to Regional until we go on Epic. Simply because the systems, what we have here, what we have at Clinton will not talk that system. So after January of next year, we'll be bringing Regional on. I have all these hospitals, I can't get the right one out. We'll be bringing Regional on with the CTP. And Regional is not currently certified as a stroke center, but everything is there because they lost it with the switch. But we are looking at working to get them certified after they get their initial visit from ACHC. That's coming. So it's kind of exciting. And Clinton's certification, we think will be June 29th. So it's coming right up. But their numbers look good. So a lot of good work with the community, a lot of good work, EMS and the collaboration between the hospital. So I think things will go well. But so thank you. You guys have any questions for me?
You can't give the T and K with the blood pressure that high.
No, has to be below, we like it below 180 over 90 to give it. So if it's high, we have protocols built in where we give the labetalol, but then if we have to mention it by a drip, we do it with nicardipine.
Okay.
We have to do a drip. Yeah.
Thank you. Thanks a lot, Beth.
Thank you.
Brenda, you are up with the trauma.
Oh, you want me to go next? Okay.
Yeah, we're just gonna head.
Yeah, Jimmy.
I was late. Jimmy missed everything.
Whatever, Jimmy.
It's a little bit.
Oh, not the left.
Not the left.
Oh.
You'll go the wrong way.
Let me see if I can screw that up.
Already did it.
Good morning. All right, so this morning I just have one. This was dispatch sent out 40-year-old male. It just said traumatic injury. So 911 calls at 9:23, the dispatch 9:24, en route at 9:26. They were on scene at 9:43. This was way down in the south end, like Prairie Creek-ish, close to Farmersburg area. At the patient at 9:44. They departed the scene at 10:01, so they had an 18-minute scene time. We're looking for that 10-minute scene time, but there was specific documentation in this EMS chart, and it said extended scene time due to stabilizing injuries, controlling bleeding, and preparing patient for transport. So it spelled it all out for me. EMS report said sitting upright in an ATV on EMS arrival. So the patient had been trimming trees on his property with a pole saw. The branch fell, hit him in the back of the head, then proceeded to land on his leg. So a tourniquet was applied by volunteer fire at 9:38, and then a bandage. And by the time EMS got there, they weren't able to palpate a pulse, so it was working well. He had a 2-inch laceration to the back of the head, and then they had SAM splint around that leg to kind of stabilize. No consciousness, no blood thinners. The patient actually told me in the trauma room that when the limb landed on his leg, he went to pull it out because he knew it hurt, but he said it didn't hurt as bad as he thought. As bad as this injury is, he wasn't putting that all together, but he pulled his leg to pull it out from underneath the limb, and his leg moved, but his foot did not. So it was kind of a,
One, then did he hop or something?
yeah. And then he proceeded, I think he ended up on the ground, but then he got up and he hopped to the side by side because his wife was mowing on their property, but she was over on the other side with like her AirPods in, just mowing. And so then he called, I believe he's the one that called 911 and drove over to where his wife was. So, whatever. So 9:55 EMS was able to get an IV started. They did a 3-lead. Those initial vital signs, not terrible, but he is obviously hypotensive. So they started some fluids. They gave him some pain medicine. They did go ahead and give that Capsol, so we love to see that. Another dose of hydromorphone in route, and then another one right before he got here. And then you can see at the last set of vital signs before he got to us, his blood pressure had stabilized quite a bit. The IHERN report that was called in is just said tree limb, open tib fib, tourniquet, the bleeding was controlled, and then the medications that were administered. So this was activated initially as a level 2 trauma at 10:24, I believe. So prior to the patient arriving here in our ER, which is what we want. And then shortly thereafter, it was upgraded to a level 1. So this is the patient's injury.
I think it
This
came in
specific
as
one.
an amputation, didn't it?
No, but we were getting stuff from other people outside that were telling us
Okay.
like radio traffic that it was like basically paying off. Yeah.
Okay.
So it didn't, you couldn't tell how bad it was when it was all wrapped up.
Yes, Jack.
So ER physician was at the bedside right after arrival. They took the tourniquet down and the bleeding was fairly controlled. There was just like some constant oozing, but nothing crazy. X-ray was at bedside, blood bank got there in time, ortho was paged timely. But they did upgrade it to a level 1 just for, we weren't sure if there was a vascular injury here.
Yeah.
So we went ahead and upgraded it. Lab work initially, CBC, CMP, type and screen, that was all unremarkable. Imaging, X-ray of the right tib fib. Let's see, it says fracture of the distal tib fib with 1 shaft with posterior displacement and apex anterior angulation of the fracture fragments. Bony fragment posterior to the tibia, soft tissue swelling and gas. We also did a CTA of that leg to make sure there was no vascular injury. It showed patent arteries, diminished anterior tibial artery below the fracture line, and that said that was likely a spasm with no active bleeding. So T-head, C-spine, that was all negative. So this is, you can see how it's fractured posterior. I just thought it was a good view of, so you could actually see the fracture itself. In the trauma bay, when you were looking at it, you can actually see like the muscle and the bone and the whole bit. I don't know if it's super clear. Yeah, like it was rather impressive. So like I said, we paged ortho, so they have a 30-minute arrival time for these big ortho injuries. And so we had ortho at bedside at 25 minutes, so that's perfect. Trauma surgeon said admit to hospital service, we'll do a trauma consult. So ER diagnosis, right tibial fracture, crush injury to right lower extremity, tree limb, scalp laceration, head trauma. This patient was taken urgently to the OR as soon as one was available. So he had an extensive debridement, and they used Aricept, which is like an antimicrobial washout because there were leaves and bits and all sorts of stuff in that wound. They determined initially that wound was not going to be able to be like sutured closed. they were able to rotate that muscle flap around, and then they just put a big rod in and nailed it essentially. And then they pulled a skin graft from his right hip thigh area, and they were able to cover that in one surgery. When Dr. Fern was at bedside, he told the patient and the wife, he's going to get an X-fix. We're going to have to do multiple surgeries here. Like, I don't think I'm going to get in there and see. Turns out he only had to do the one. Like, so I don't know if it wasn't, I mean, he was just able to get everything to line back up just perfectly, but they went in thinking there were going to be multiple procedures in order to repair this. So that was kind of cool. So hemoglobin on arrival was 12.1. On hospital day 2, his morning labs, he was 7.8. They did order a repeat hemoglobin for later that day, and it trended down to 7.3. So they did go ahead and order blood transfusion. So he had 1 unit of packed red cells that day. He did go ahead and work with PT and OT, reported dizziness with standing, obviously. And I think that was part of the reason they did go ahead and transfuse and didn't just like wait because he was symptomatic. And then ortho saw the patient, IV antibiotics for 72 hours. And then he had a wound vac where that skin graft was. So day 3, he continued to trend down despite the red cells to 7.1. So they did order another unit of cells that day. There's nothing really to talk about besides that day. Day 4, kind of the same thing. He started trending up this day, feeling better. He worked with PTOT. And then day 5, hemoglobin was 8. I actually went up and saw him that day. You could tell he was like worn out and tired, but like doing really well, like had a boot on his leg, was able to like move himself around in bed. I mean, he was a 40-year-old young active guy. So ortho came, removed the wound vac, that they were good with discharge. He got up and ambulated, which is wild. Like he moved to toe touch weight bearing after that wound vac was removed. So he ambulated 80 feet with a walker and PT. And so everybody was like, okay. And he was ready to go home. He wanted to go home. So he went home with his wife. He refused home health care. I did look in his like follow up with ortho. He's been back to ortho. It might be twice now since I've done this, but the only thing that was in there, x-ray alignment was looking good. The skin graft was looking good. The only thing they said that there were a couple little areas of necrosis that they were watching, but it should be small enough areas on that graft that they should heal with no problem. So there's that. So I think great job to EMS because they got the Capsol, lots of pain medicine for him, got the fluids because he was obviously a little hypertensive at the beginning, got us here, did all the good things. And then I think it really impacted like his outcome because he's not showing any
Yeah,
signs.
because that's not
of infection or
typically an
anything.
injury we would have kept. I mean, if you
We were kind of surprised that it
Yeah.
stayed just because it looked so
even
bad.
a year ago, I think he would have immediately transferred but that's kudos to everybody.
It was gnarly. I mean, it doesn't do, it was even, the part about it for me was I was in there with those guys and lifting his leg. I mean, when we went to put his leg back down, the upper portion of his leg went down,
Yeah.
but the rest of it stayed up, and we're trying to keep it level and straight, so we had to put another pad underneath it, another sand splint underneath it to try to just hold it steady. And then we had to build up a bunch of pillows because he didn't
He
like pressure.
couldn't get him
which-
comfortable, yeah.
couldn't get
Yeah.
us a-
Yeah, he was tough. Did a good job.
Yeah.
Like,
Yeah, he should have been in way more pain than what he really.
Yeah.
I wonder.
Yeah, really, that wasn't a lot of pain medication.
That's a lot.
no, but like,
Injury.
just to me.
Yeah.
I don't know.
Put me down.
Just get a drip.
I'm not hopping anywhere.
I wonder how much not having a fractured fibula helped him.
Oh, I'm sure.
Cause he still had that one stable bone in
Yeah.
there.
Yeah.
Yeah, but it sure been, it sure moved.
On that.
Yeah,
It sure was paradoxical in a lot of places. I would have bet both of them.
That bone doesn't do much, but it did.
That scenario supports the fact of two things, the antibiotic and how critical it is.
Oh, sure.
Because honestly, had he not had that in the field, then you're talking a couple hours. And that was a nasty wound. And the blood loss, especially when you're teaching babies, like those orthopedic injuries bleed. They bleed a lot. And, even that young healthy as good as well as he did he still ended up with what, 2 units, 3 units, whatever it was. And I'll say we had another open fracture this like a week before from like in the city. And that one was very well managed also, like they had their antibiotics given, like they did all the things like so that 2 in a row, like super good, like.
Well, thank you, Miranda. Next up is Jimmy McKinney. He's gonna do some capnography for us. And I'm sure he's got a lot of good things.
Oh, thanks, Frank. Okay, right here. Yeah, the right. Okay. All right. I'm Jimmy McKenna, Director of Respiratory Therapy, and remote patient monitoring, a couple of departments at the hospital. But I usually do talk about capnography just because I think that the respiratory therapy side and then also the pre-hospital side, your teams understand this as our teams do and how it is coming up as the 7th vital sign. And so I took an old presentation, kind of toned it down a little bit, put some new information in. If you've seen this before, there will be a couple new things. So capnography obviously is the measurement of CO2. And so I have a tough time standing back here. Let me see. Well, I'll try. Okay, so the best thing is to understand where CO2 actually is first produced in metabolism and then how it's gone through, perfused through the body and then released from the body through the lungs. And so a lot of times we do think about anytime I'm teaching anybody about arterial blood gases or whatever it be, I always say ventilation is synonymous with CO2. So whatever the CO2 is, it tells you about their ventilation, and ventilation is air coming out, not air going in. So getting air out, but understanding that at the cellular level, you can look at the entire circuit of how it's produced from the mitochondria and aerobic metabolism through the Krebs cycle. And I used to have the whole thing with Krebs cycle. We're not going to get into that. And then perfused around the body. So it's perfused obviously by the heart, pushed around the body. When it comes past the lungs, it's dumped off at the alveolar capillary membrane into the alveoli and then ventilated out. So it's a couple good points to know with that is that when you have a cardiac arrest, you will at that point no longer have that middle stage in there, that perfusion, and it will stop having any production at the alveolar level. So there always is going to be some residual. We have about 100 milliliters of what's called anatomical dead space, anatomical and physiological dead space between the area of our lips and actually our terminal bronchioles right before our alveoli. About 100 milliliters of space in there is all mixed air. So when you do have cessation of somebody's heart stops, you are still going to have some CO2 that's going to produce on a capnography for a few more breaths. And it's usually about 3 to 5. It matters kind of if you're taller, it might take a little bit longer. About 3 to 5 breaths, you're still going to see some CO2 coming out because you're cleaning out the anatomical dead space. But at the alveolar level, you're no longer going to have it coming in. So something real key. So the anatomy of a waveform. So the waveforms, they're a little bit backwards to what you're used to. If you're used to running mechanical ventilation, this does kind of look somewhat like the opposite of a descending ramp waveform for pressure. But you're going to notice initially, I think you might be able to see this. Okay, cool. Yeah, so this is exhalation only. So this is, you're going to have your initial baseline. The initial phase 1 is inspiration. So phase 1 is right here. That's the initial breath in and then the expiratory upstroke. So as you go to exhale, this is what you're going to see as they exhale. And that's going to go up from 0, should always start at 0, and it's going to go up to a plateau. And so what this area right here is this is actually dumping of that 100 to 150 milliliters I was talking about from the anatomical dead space. So there's a mixing of air in there, but once you exhale and you get that first 100 to 150 milliliters out, that's where you'll be actually dumping your alveoli, and that's where we start to read. We get into right here, this phase 2 part right here. That is the alveolar emptying area. So first 150 comes out, that's this part, and then you're going to have your actual readings coming off right here. Now, when we measure end-tidal CO2, it is at that plateau space, which is right here. So it is right at the very end of phase 2. beginning of phase 3. So what you're going to have the beginning of end of upstroke, you're going to be in phase 3 at this point. So at phase 3, you're going to have your end tidal is read right at this point. This should be a slightly up ascending waveform. And then if we're going to look at a number, it's going to come from right here. So that's where the number is going to come from. But the waveform is extremely important. And then the downstroke, you have a full exhalation. At the end of your exhalation, that's where we're reading the end tidal CO2. And then the upstroke is them taking their breath back in, going back to baseline. You should see that each time. So that's what the waveform should look like. It should be a slight upsend, but we're going to talk about some morphology of that and looking at different disease processes. Okay, so gold standard, we know this, and this has been going on since 2020 and before, but it's continued in the current guidelines that capnography is mandatory when you're looking at placing advanced airways or supraclonic airways. So the recommendation is continuous waveform capnography to monitor the reliability and to confirm that you have correct placement. Now, when we teach residents, when we teach new respiratory therapists, whoever with intubation inside the hospital, we always say number one is actually visualizing it going through the cords. And then we have multiple things. We have capnography as actually number 2 and we even look at that before chest rise because it can be very subjective when chest rise, especially with somebody who has late stage emphysema and barrel chest and whatnot. So capnography is number 2 when we're looking at detection of that. Now, number 1 is kind of cool because we use inside the hospital, we use a lot of video assisted intubation. And the great thing about that is when we're video assisting an intubation, not only I can see it go in, but Jackie can see it go in. Anybody else that's in the room can see it pass through the course, and it just gives that reliability. Capnography is the same way because it is going to be a waveform that everybody should be able to see at that point. So you can see that waveform pop up and then maintain after that tube is put in. If it's an esophageal intubation, it's going to look just like the one on the screen. That's bad, right? It actually, they're probably doing CPR in this case, but it's maintaining. And then you see I have about 5 breaths or so. That's an esophageal intubation. You're not going to have 0 CO2 coming out. One of the main things that we see, and it's throughout the house, through everywhere, is since the technology, it's not new, but it is kind of new to watch. We think that the technology doesn't work. And so it's very important to, before you say, I don't think the capnography is working, to really make sure you're going back and checking everything to make sure maybe I should be trusting the capnography. There are options for it not to work. If you're using a side stream method, it's got to pull a sample back to the capnometer inside the defib or whatever it is. If there's mucus stuck in that, it will stop. It should give an error, a vacuum error, and it's different on different machines, but it'll say that it's not able to pull a sample. So then at that point, you can change out to new cuvette or whatever it be, but that would be the time where the equipment would work. But if you ever get a waveform and the waveform's not showing, that should be an indication that I really need to make sure, go back and check because my endotracheal tube is probably not in. I can't just blame it on mechanical error or equipment error. So it also detects dislodgement, which is always very important because, in the pre-hospital world, there's a lot of moving and shaking. We get them and we put them in bed, especially at night, and we ultra secure tubes and all the tubing. And so we don't have a lot of dislodgements unless they grab or the patient is being rotated. But in the pre-hospital space, if you get a tube in, you really want to make sure you're maintaining that all the way in to the ER until you have a handoff. And so capnography is a great way that if there's jostling or moving or whatever's going on, is that you can watch that capnography to make sure that it's maintained throughout in the correct space. And interesting fact, I know that if you would happen to some case, let's push it down in the right main stem. Let's say it was a normal, it was about 2 to 3 centimeters above the carina, but you push it in the right main stem, you're still going to get the same amount of CO2 coming out. It won't affect the number at all because you're going to be getting it from one lung. So you can't tell right brainstem intubations from this, you can just tell that you're in the lungs. So I've not seen any studies where they look at right brainstem intubations. So also you use chest rise for that one. Unlike lung sounds, capnography is very objective, and then also it's essential for identifying esophageal intubation. Okay, so CPR quality, we all know that the goal is above 20 for CPR quality to make sure that we are getting good perfusion, because that was number 2 on the list. We have metabolism, perfusion, and ventilation. So we have to have good perfusion to get it by the lungs. And so as you're perfusing that blood around, you should have at least 20, and that's the goal for high quality. Low quality end-tidal CO2 consistency below 10 suggests that there's poor compression depth and rescuer fatigue. And so as working as a team, we know it's very important to make sure that if you're seeing that you are using your team dynamics that we're taught in ACLS and changing out that compressor, because they could be wearing out. And then also used as a guide for rotating those compressors when you're working in the ACLS. So at low CO2 doesn't always mean the patient is dead. It may mean your compressions are just ineffective. Because even dead patients, you can get CO2 on as long as you're pushing it around. So predicting ROSC, and so this is just broke down kind of over a certain amount of time. It's a great opportunity to predict ROSC. We've seen this, and it's always a light bulb for respiratory therapists when we do get ROSC inside the hospital, and you see you're doing the CPR and you're watching capnography, and then all of a sudden they're not usually looking at the waveform because it could be a little funky, but they see that number jump by about 10, and then they can already predict that the next time they do the pulse check, their patient does have ROSC. So always a light bulb. We love when our therapists are able to see this actually happen, because it does drive in how important it is to have capnography on. So you'll be able to see ROSC really prior to that check, which is really important. All right, so morphology of waveforms. I always talk about shark fin. I think it's the most, just because I'm a respiratory therapist, in looking at not necessarily diagnosing, because we can't do that, I guess, but we're looking at what could be the morphology or pathophysiology behind what's going on with the patient. So you can tell this is obviously a normal one on the bottom, but you can see the obvious shark fin, and they make it super simple, because what is happening in this case of a shark fin is a lot of times you're going to pick the patient up, you're going to listen to their and this is going to be our spontaneously breathing patient. They're going to have bronchospasm. You can listen, you can hear wheezes, and is it dry, is it wet? It's really hard to tell. Is it heart or is it bronchospasm? If you see that it is a shark fin, what that's going to tell you is it's true bronchospasm, and that's what makes respiratory therapists really excited, because that means our albuterol is going to work. So we can keep giving a ton of albuterol, and we know we can fix this problem. So the shark fin is showing that it's true bronchospasm, because what's happening is instead of having that alveolar emptying here, it's taking a long time to empty those alveoli because the bronchospasm is proximal to it. So it's having to squeak out different areas, and that high level of CO2 inside the alveoli is taking a long time to get up to actually where it's exhaled. And so the shark fin is a great number. Now we would still see, and we're going to still see a number that comes up for capnography, but looking at how the waveform actually is formed is really going to tell you a lot about what's going on inside the body. Now, a patient that has a CHF issue, that they won't have a shark fin, because with CHF or fluid, you're going to have that problem is more at the alveolar level and not at the conductive tissue level. And so you're going to have equal alveolar emptying. And with a CHF patient that has wheezes, that's non-bronchospastic, it's going to look like a normal exhale CO2 that you would see on the bottom. And so we still give albuterol for these people, but we know that there's probably more of a fluid issue or heart failure issue than truly bronchospasm. So shark fin, you get excited about seeing the shark fin, because you can do something maybe quick to take care of that. Also for sepsis, this is for maybe longer times that you would have, but using this on spontaneous breathing patients is extremely important. There has been a lot of data done looking at sepsis and metabolic shock. The predictive value is less than 25 for a spontaneous breathing patient is 90% sensitive for severe sepsis and EMS. So you would actually be able to tell, because with sepsis, what's going to be going on is they're going to be compensating, especially if they're into septic shockish. They're going to be compensating, the respiratory system's going to be compensating for their metabolic system, and so the respiratory rate's going to be up. And so with the respiratory rate being up, you're going to see a lower exhaled CO2, and that's just a nice predictive tool that you can use for that. And also a lower CO2, there's a lactate correlation to it, but you're not going to do lactates in the field, but lower CO2 directly correlates with a higher serum lactate, which is going to give a better indication about sepsis in those patients coming in. So these would be patients sick at home for a long period of time, put capnography on them, and you would see that lower amount. Now, there's been a lot done throughout my career and many of our careers when it comes to traumatic brain injury and hyperventilation. And it's always, you know, I think we went from hyperventilating to now we are at the point where we are targeting really close to normal exhale CO2 on our traumatic brain injury patients. And the only way to do that, and I remember we didn't use CO2 when I first started, and it was like just breathe at a normal rate. But now we can actually target the exhale CO2 when we're looking and doing manual ventilation. So it's also nice if you have somebody that's, if you're a smaller crew and you have somebody who is ventilating for you that might not be a medic or whatever it would be, you can give them that area to target for traumatic brain injuries. Because we know that hyperventilating obviously does decrease the blood flow to the brain for those bleeds, but then hyperventilating also causes problems with interthoracic pressure and decreasing their overall pressure for their body. So by pressing on those great vessels. And so we really need to be in this normal area of 35 to 45 when we're looking at exhale CO2. Unless it's active herniation present, but it's really hard to tell that in EMS world. So targeting this, we used to kind of ventilate them definitely below 35, but 35 to 45 is really key. Is that what you're seeing? Are you targeting this with ventilation in the field? You looking at this, or just saying bag them a little faster, or bag them a little?
I actually just are doing a protocol update test, and believe it's 10 to 12 breaths per minute is what our protocol state right now.
Which is normal. Yeah. So essentially, you're making it 10 to 12 breaths per minute, one every 5 to 6 seconds, and then it should put out a normal CO2 of this. Yeah.
I forgot to get back the bank card.
What's that?
Why didn't get themselves muted?
Oh. Well, those didn't come through very well. Well, there's some stuff in here that you can see. I'll change that, honestly. You'll get that in the packet. It actually is a lot of kind of cool information. It breaks down, I made it white. For some reason it didn't come through. It breaks down oxygenation versus ventilation. Honestly, if you look back, this is a really good thing to look at because it talks about the difference between oxygenation and ventilation. I love talking about these things. It talks about the measures of them, the timing of them, the first alert, and the influence of oxygen. And I know that in the EMS world, RT world, we know that FiO2 doesn't affect ventilation at all or capnography. But we'll send this slide, and I think that it might look better in the PDF form. So that's a free hat. Yeah, free through that one. So, all right. So other things, it's just key EMS research that they're looking at. Obviously, the EPIC study looking at pre-hospital TBI studies, and this is on that normo ventilation we would do for our patients. It's really important. Sepsis screening. There's also some talks about that with SIR scores and the quick SOFA score for patients. Interesting things to look into if you will have more time. And then AHA guidelines update, looking at for high quality CPR. So capnography is being added in as the 7th vital in many different spaces. All right, so I have just at the end, just a few of these. And I'll take, these are just question and answer. So what's going on with this patient, with this capnography waveform? You don't have to say a disease process, but just what is the problem? Increasing, right? So hypoventilation. So if you're having hypoventilation, how do I know that? You probably won't see it this dramatically, but over time you're gonna see, you see the endpoint of each of these. This one's about 39-ish, this one's about 43-ish, and then it's going up over time. What's that showing is they're hypoventilated. So a couple different things going on. Always check your equipment, but maybe you need to.
Why do you have to call Peter for?
Hey,
Somebody's not muted.
somebody's not muted.
I wish Peter knew the answer to that. You know the answer. Anyway, good job. This is hypoventilation. All right, so we know this is sharp fin. What does it mean clinically?
I need a
What the heck? Yeah, I don't know what protocols are. I'm a big fan of just giving it until they just shake. It actually works at that point. I mean, I'd rather shake and be able to breathe. It's gonna wear off. So yeah, that's uneven alveolar emptying, and that's the shark fin. Oh, this is a little tougher. I do have gifts I'm giving too, if you're getting them right. So I have only 2 of these. I don't know if you have one of these. I sell these on my YouTube page. So I was giving away for free. It's oxygenation ventilation. What's the problem with this? Hypoventilation, but look at the baseline.
Yeah.
This is, you're gonna look at your equipment, they're rebreathing CO2. They're not actually coming to baseline each time. And so they're rebreathing CO2 in some case. So there could be a lot of different issues going on with this mucus plugging inside of your system, whatever it be, but this is really cool for capnography because rebreathing CO2. So. Oh, this one, what's this one? That's not good. Dislodgement, esophageal inflammation. Oh, this is a little more tough. Air trapping? Yes. Well, no. I was gonna give you a little bit, no, not totally air trap. This one is more, you're probably not gonna see this quite as much unless you have one with a ventilator. They call this QRA cleft. Just a little Jeopardy, which will never be on Jeopardy. But what it is, it actually is when
What'd you say it's called?
QRA cleft.
QRA.
Yes, the QRA cleft. And so what you'll see is that they're having breakthroughs in their paralytic. So they're actually taking a little bit of a breath at the top. At the top. All right, that's QRA cleft. That's the thing that's the day. So
So they're fighting through it, trying.
yeah, that's right. So and then is there any questions at all? Yeah.
Well, thank you so much.
Yeah, no problem.
Yeah.
Much appreciated. Like and subscribe to my YouTube page. I have 3 more people to get to 30,000. So
3 of us have to sign up today, is that what you're saying?
actually, I'm already over 30,000. I'm at 30,005 this morning. I checked.
This is for anyone out there. You have a QR code or so you can register to get credit for this. This will be going up on YouTube at some point in time. Couple things I want to talk to you about. There's going to be some updates to some protocols. There will be a protocol test that'll be coming out for everyone to take. More to come on that. We'll probably go into the year to make sure you have those, everybody has those done in a certain period of time. That will come from your department and we'll discuss that. Please don't forget, next week on Thursday, May 21st is our EMS luncheon for EMS week. We're going to be at Regional Hospital from 11 to 1. The mayor will be there at 11:30 to do the proclamation. So please come down and have lunch and join us. Rick Barbecue again. And fire department, Transcare, everybody, and area back are all supplying some stuff for us, drinks and desserts and such. And there'll be gift cards given away. The trauma department has are going to be giving away a really nice pair of Raptor shears. There's the potential that you may have to get an IOU because the shipping was delayed is what Jackie told me. So there's a possibility. So really good things coming up next week. I wish everybody, does anybody have any questions online? Anybody here have anything to add? Did I miss anything? Should have called Peter. Yeah. Well, if that's all, you guys, I appreciate it. I'm gonna go on mute, but I'll leave this up on the screen for a while for you. Thanks, everybody.